header on the top, so hopefully I won't get any legal trouble because it is actual proof. So the next day when as you can imagine, we were pretty upset with leaving his clinic. And the next day I was to meet with a neurologist, and again, my only meeting with her. I went into her room, and because I had told him this, and he said, well, bring the questions to her. I went into her. First of all, she said, what are you doing here? I'm not supposed to see you for another 6 weeks, but kind of you're here now. So that took me back as well. I handed her the list. She just took one look at it and looked at me and went, oh, no, you could never have a child, and handed me back the list, considering she'd never met me. So as you can imagine, it had quite an impact on us. But afterwards, years later, I actually came across this particular piece of information that was from, potential implications of the Equal Status Acts for Assisted Human Reproduction. The report of the Commission on Assisted Human Reproduction states that subsection 4 of the Act provides that where a person has a disability that could cause harm to that person or to others, treating the person differently to the extent necessary to prevent such harm shall not constitute discrimination. So I took that to mean that really, if I'd even taken legal advice about the way I had been treated in her unit, the law would not have protected me. That would be my understanding. So I'm really interested to hear presentations today in the hopes that perhaps we've moved past that at this stage. But I wouldn't be too hopeful, I have to say, as a disabled person. So for a number of years, I can imagine, we did nothing. We were just we didn't know where to go. We tried inter-country adoption, but that was awful as well and very discriminatory. But of course, that's a story for a different panel or a different day. So if anyone's interested, come to me later, and I'll give you the sus then. But then in the early 2000s, a colleague I was working with happened to mention that she was going for IVF, and she had very good things to say about the private clinic she was going to. So we thought, okay, we'll give it a try. Maybe things have moved on. We'll see what happens. So we went there. You may have noticed there was a show last year about a fertility clinic in Dublin called The Sims. Well, we actually went to them, but they were much smaller back then. And it was a completely different experience. The fact that I was disabled wasn't an issue as in a problem. It was just something to be taken into account to factor in for the medical treatment. And we were totally taken aback at how positive and welcoming and open they were. So that's when we realised, okay, well maybe we can do this. And we went through the process with them. That's how we ended up with the failed IVF. And then a few years later, we tried again one last time, actually ended up full circle back in the Coombe on my 4th pregnancy. And we ended up in 2007 with our little miracle. She was very tiny because she was 11 weeks early, and the Coombe were very good in actually facilitating access for me. They kind of put her in a room, quarantine on the doors, and nobody else would use it, and it meant that I could actually make it accessible for me because she was 2 months old when she finally came home. So I thought the reason why I wanted to share that with you was say, throughout it we met a lot of negativity. And I've often thought to myself, I'm a very stubborn person. You tell me I can't, I'll prove to you that I can. And all through it, I believed that they didn't know me. I knew me, and I knew what I was capable of. But I've often thought to myself, how many lives has that consultant ruined? How many lives that neurologist ruined by saying no? You know, and it really kind of struck me, so I was delighted to actually be part of this today, to actually just kind of raise that and share that story. A lot of barriers, of course, were apart from the attitudes. Physical access for someone with a mobility impairment is just a nightmare. The amount of times I had to be dragged onto very high examination couches, or in the early stages, one of the miscarriages have to be carried down 6 steps into the early pregnancy assessment unit, and all these different physical barriers really made the whole process. And really, when you think about it, like if you're non-disabled and 8 months pregnant, you're being asked to hike yourself up onto a ridiculously high examination couch. That's when it comes into universal access. It's making it better for everybody and not just disabled people. And, those who provide these services need to actually understand that it's not just about attitudes, it's also about access. I do have a little bit of information here that I just wanted to show you as well, just that relates to the following presentation in relation to contraception. I discovered a really interesting chart in a book written by Mukti Jan Campion. It was called The Baby Challenge, and she took it from an American book, and I've never actually seen it anywhere else. So I'd be interested to know today if such a thing exists now or not. But it goes through all the different types of contraception and how it may interact with someone's impairment, or how certain people might not be able to manage and that sort of thing. It's actually a really useful chart, and I really hope to see if something more up to date and in Ireland could be brought about. So I just thought I'd share that with you as an interesting piece aside. But in conclusion, because I know we're just getting close to time, I just want to say it's really important that you always remember that you are your expert on your body, despite what the people with the lovely pieces of paper say. So it's really important to kind of fight back, know where you want to go, and believe that no matter what they say, you can actually get there. And just a chance to find people who are like-minded who can actually support you. Because when it comes to fertility, whether it's not wanting to become pregnant or whether it's wanting to become pregnant, for me it was a case of wanting to. And the desire to become a mother was so strong that the only way I could kind of keep sane was to believe that no, they're wrong, I'm right, and we'll get there. But not everybody can do that, not everybody can be supported to do that. So I think it's really important. Events like and projects like this are so important because we need peer consult, we need to peer support, and we need to work together to actually move things forward into a more rights-based, universal approach, so that people can be, like if somebody wants to be childless, that's great if it's through choice, but nobody should be forced to live like that just because of bad attitudes or bad access. And that's it, so thank you very much for your time.
Okay, thank you very much, Selena. That was a really good kick-off to this section, and I think to the whole panel session now. Like Eleanor was saying earlier, the stories are so important, and so good to have such a really interesting story and a happy ending as well, a nice happy family. So I'll invite now Dr. Sinead Feeney from Galway West Clinic. Do you want to come up to the panel? So like I said earlier, she'll be speaking a bit about what she's seeing from the other side of the doctor's practice.
Thank you all very much for having me here. It's an honour. Lena, thank you for sharing that story. It's very harrowing, and I think it's really important that it's called out, because those attitudes that you experienced should not be tolerated, absolutely not. And I would like to hear that person that wrote that list for you here's back and here's your story and gets called out on it, because doctors we're just people like everybody else, and we're all learning. And you are absolutely right. A person with a disability, just like any of us, we are all experts in ourselves. And I consider my job as a general practitioner to meet a person where they are, regardless of what challenges they may have, 1 in 7 of us, of course, has a disability, and if we all live long enough, all of us will have a disability at some stage in our lives. And I am absolutely not an expert in the multitude of disabilities that can affect a person at any given time, and no one person could ever be. And the term disability is so incredibly broad. I think if you encounter a medical professional or anybody else who gives an attitude like that, then they should be called out on it, and that is clearly very harmful. Our job is to try and help people be the best version of themselves, and by the sounds of things, both those encounters, and by the sounds of things there was more than just those two, have been very damaging, and you've carried that with you. And despite, I'm sure, meeting other people that have been helpful over the years, that's caused real harm. That should be called out, and I hope that this work will help to educate the wider populace. But really the attitude that we should all have is exactly that disability is on a continuum with ability. We all have various abilities and disabilities, and when it comes to having a child or being involved in relationships, it's a very primal human urge to have relationships and have human contact and have sexual relationships, and some people want to procreate and some people prefer not to, and all of those urges and choices should be respected and encouraged. And I'm not an expert on fertility. I know that if somebody wants to get pregnant, they should try to be as healthy as they can be themselves. Everybody should be taking folic acid, and all the various organisations, national organisations and international organisations for various groupings have their own programs. So if you go to, say, a conference for osteogenesis imperfecta, there'll be a group for teenagers, maybe, about relationships and sexual education and that kind of thing. And while I don't know of anyone, say, for example, who has severe osteogenesis imperfecta here in Ireland who has had a child, there are loads of women like that in the States. So it is absolutely something that can be supported. But I don't want to dwell on any particular disability because it's impossible to generalise. Each person is an individual, regardless of what their level of ability or disability is. Really, any medical centres that have been built in the last number of years should be completely accessible from the point of view of wheelchair access, and I suppose it's attitudes. Not every medical centre is going to be able to support people at the same level, but I think everybody will at least try and meet the person where they're at. The other thing is there is a service called Sign Language. There's an Irish Sign Language translation service that I only recently became aware of, and I just wanted to flag for anybody who is deaf and uses Irish Sign Language. There is kind of a Skype service that's available. And we do, I suppose general practitioners are kind of problem solvers. We deal with every kind of thing: a gouty toe one moment, somebody with cognitive impairment, and then somebody with a chest infection, and then somebody who's planning a pregnancy, somebody who's trying to avoid a pregnancy. We deal with the full spectrum, from before birth to right to somebody's dying breath. So we're very much generalists and problem solvers, and we try to support people wherever they are on their journey. So I better move on. So just talking about sex and relationships, if you are a person who wants to engage in a relationship, and you want to come in and you want to talk about contraception, whether you want to come in on your own or you want to bring a support person with you, that's entirely up to you, and provided it's kind of driven by you, that's fine. Condoms, obviously, very important from the point of view of avoiding sexually transmitted infections. But if you find it difficult dexterity-wise to use condoms, then once it's an informed choice that you're going to have sex and you're aware of the possibility of sexually transmitted infections and health screening, that's fine. Combined oral contraceptive pill. So Celine put up a nice chart about the various pros and cons for various forms of contraception. And really, if someone's coming in to talk about contraception, we do go through that. It doesn't matter, who you are, because everybody has some reason why the combined oral contraceptive pill, for example, mightn't be ideal. So somebody who's got a higher risk of, say, thrombosis, so clots in their legs, or pulmonary emboli, or stroke, or anything, it wouldn't be suitable to be on the oral contraceptive pill, or if they've got difficulty remembering to take the pill. In reality, across the board, 8 or 9 women per 100 women get pregnant every year taking the oral contraceptive pill. So it's not a great form of contraception for anybody. And in general, we don't really recommend it, but it can be helpful for somebody maybe to regulate their period or to avoid having a period. And if they're an excellent pill taker and they don't have a particularly high risk of thrombosis, and they're not on a number of medications that might make it less effective, then maybe that's a good choice. But it really is an individual thing. Progesterone-only pill, it's not a great it's not a great option, but in certain circumstances it's okay. But it's less effective than the combined pill, more likely to have spotting and various problems like that. This is the Evra patch. It's the contraceptive patch. You just change it once a week as opposed to taking a daily pill, so it can improve compliance. But if you've got a serious skin condition, that might not be suitable for you. And again, if you've got those same risk factors for thrombosis, which would include things like a migraine with a visual aura, that wouldn't be for you. This is called a Nuva ring. It's the same thing, except you put it in vaginally, you leave it in for 3 weeks, and you switch it out every 3 weeks. And again, it improves compliance, and it's good for people maybe who have issues with swallowing or that. People in Ireland are kind of vagina phobic, so no matter who they are, they're not. There isn't great uptake for this one, but in France, for example, people seem to love this one. This just brings us on to LARC methods of contraception. So LARC is long-acting reversible contraception. So this is considered to be way more reliable when it comes to trying to prevent a pregnancy. There's a few different types. This is just showing the Marina coil, which is an intrauterine system. And this was revolutionary when it came out to help with lightening periods for people who had very heavy periods, and it can be inserted and left in for 5 years. We insert them all the time in general practice, but if somebody has any particularly high-risk conditions, so if they've got a cardiac arrhythmia, or their anatomy is particularly tricky, or they've issues with chronic pain, or if they would find it difficult maybe to get onto our couch, it might be better to have it inserted in theatre with monitoring, but once it's in, there's no monitoring required. I noticed on your slide they were kind of saying it mightn't be suitable because you can't check the strings. This device, it sits in the uterus and it thins the endometrium, so you don't really get as heavy bleeds, or you might get no bleeds at all. And then the little strings hang down into the vagina, and that facilitates removing it after 5 years. And the old advice was to check those strings intermittently. The new advice is don't bother checking, so it would be fine once it's in. The copper coil is a great form of emergency contraception. I just wanted to flag that. People don't know about the morning after pill. Nobody seems to know about the copper coil. Morning after pill isn't a great form of contraception at all. The copper coil is an excellent form of contraception, and it can stay in for 5 to 10 years. But the major issue with it is it causes heavier bleeds. So if you're somebody who bleeds for 5 or 6 days and you use 5 or 6 pads or tampons in a day, you're going to bleed for longer. You might flood and that kind of stuff. But if you're somebody who wants to avoid any form of hormonal contraception, it might be a good option for you. The Depo-Provera, often this is it's got pros and cons. I don't love it. It can cause, so it's an injection that you get every 14 weeks and into the muscle. And it's a big whopping dose of progesterone, and it generally leads to amenorrhea or no bleeds at all. Very reliable form of contraception, but it involves a trip to the GP's office every 3 months, and it can lead to weight gain and kind of fluid retention, and it can also have an impact on bones. So if you're an issue, if your mobility isn't so good, and osteoporosis is something that you're worried about, or you're worried about weight gain and that kind of thing, and all those trips are a hassle, it might be a great option. Implanon is generally a great option, very easy to insert. It is a very low dose of progesterone versus the previous one, which is high, big dose of progesterone. The Implanon is a little implant that goes in just underneath the skin on the inside upper part of the arm. It can stay in for 3 years. It's very well tolerated generally. It can be removed at any time, and you immediately return to your fertile state, and you get maybe a little bit of spotting would be the only problem with that one, but very reliable. Don't have to remember to take something every day. And people are generally very happy with it. So I'll leave it there. It's a huge topic. I brought a few toys, so I brought a few versions of all these LARC methods just in case anybody wants to come down and just see what they look like. This is exactly the same thing that applies to everybody. It doesn't matter whether you've got a disability or not. And basically that's the message. You know, if you happen to have a GP, and I hope you don't, who has any kind of negative attitude towards you and your choices, then you don't have to stay with that person. And you should, or if you choose to, you should call them out on it and educate them. So be brave.
Thank you very much, Sinead. I learned a lot there. Kind of thought I was fairly knowledgeable on contraception, but no, definitely fit for that. And great to see such positive attitudes towards inclusion and acknowledging the barriers, but knowing that there are people in the industry that little steps to making experiences better. So we'll turn to Ciara now, talking about the assisted reproduction bill.
Okay, good morning, everyone. I'm going to offer some reflections on the new bill that is currently undergoing pre-legislative scrutiny. Selena, I don't have good news. The law isn't going to drastically change from your own experiences. And I must be honest, before asked to give this talk, I hadn't actually really thought about it from the point of view of people with disabilities trying to access fertility treatment. And I'm not alone. There's been very little empirical work that's actually been done about people's experiences who have disability when they are actually trying to access fertility treatment. So here is what I would kind of see as some barriers to assisted reproduction generally in Ireland. It's absolutely not an exhaustive list, but I kind of just broken up into 3 different areas. The biggest problem we have is treatment is provided in the private sector only. So if you want to access it, you need to get to a private clinic, generally in the big cities. A lot of the access issues that Selena talked about you're going to face. You need a lot of blood tests. Currently, I'm a woman who has fertility issues, and as the doctors are trying to grapple with that, I am in and out to my own GP in London, as well as to various hospitals. It's expensive, at least €5,000 or €6,000 per cycle. Success rates are low. We don't know in Ireland what the success rates are, but generally internationally about 20 or 30%. So you usually need multiple cycles. VHI does provide it in certain situations, but you have to be prepared to pay. And we have a huge lack of independent information. We don't know success rates. We don't know how many people are trying to access fertility treatment in Ireland. And we also actually see this as a problem elsewhere because of the lack of independent information. There could be the concern that people are getting these fertility add-on treatments that they might not necessarily need. It's a discussion that's going on in the UK at the moment, but it's not something that we're really seeing here. There's a lack of information and awareness around the causes of infertility. It's extremely, extremely common. But a lot of people experience feelings of isolation and loneliness. And I know myself, when I was first confronted with these issues, it's quite hard to get information on it that's actually relevant to you. And as I said, there's absolutely no literature in Ireland that I could come across on experiences accessing fertility treatment for people with disabilities. The focus is always, and even with this bill, it's on ensuring that people who can access fertility treatment irrespective of their gender, their marital status, or sexual orientation. This is very much seen in the new bill that's going forward. And another problem is it's currently on regulation in Ireland. There's no independent oversight, and the clinics are essentially self-regulating. So we do have this bill that was introduced in 2017, or rather the heads of the bill. Coupled with this, the government has announced that it's going to make €1 million available for people who want to access fertility treatment, but we haven't actually seen any movement on that. And we don't know the criteria that will have to be satisfied for a couple or an individual if they want to access fertility treatment. We also don't know if it's a once-off payment, or is it going to be every year, because of 1 million every year is not bad, whereas if it's once off 1 million, access is going to be pretty limited. And we really see in the UK, even though assisted reproduction is under the NHS, it's very, very hard to actually get it, and we do see some barriers put up. But this is what the bill is going to do, proposing to do. It's quite broad, it wants to do a lot. It wants to regulate assisted reproduction, embryo and gamete donation. It wants to look at pre-implantation genetic diagnosis, surrogacy, embryo and stem cell research, and importantly, it's going to introduce an independent regulatory authority for assisted human reproduction. The discussion to date has been very much focused on surrogacy. So I'm actually not going to talk about that. I want to actually look at access generally and just leave surrogacy to one side for now. So I think in this context, what's important is we look at Head 6, which is talking about access to assisted reproduction. And it says that assisted human reproduction can only be provided to a person subject to the welfare of the child. The head goes down further and says assisted human reproduction can be provided to a woman. Note the use of term woman versus person, which is problematic in and of itself. But under the bill, it can only be provided for a woman if 3 conditions are met. First, she is unlikely to become pregnant, carry a pregnancy, or give birth without treatment. That's satisfied. The clinic needs to be satisfied that the pregnancy or childbirth would not pose a disproportionate risk to the health of the woman or the child, in line with national medical and obstetric standards. And the third condition is that the provisions regarding the welfare of the child are met. I'm just going to focus on the woman issue and the 2 different kind of tests as I see it that must be met. There's kind of like the medical assessment, that first of all, the woman is not going to get pregnant, carry a pregnancy, or give birth without a treatment. And also, the clinic needs to be happy that it would not pose a risk to either to the woman or the future child. It is a medical assessment, and there is no voice, like Selena mentioned, that there's no voice for her voice in this process. It's going to be a decision that is made by the clinic and the clinic only, and there is currently no obligation to consult in making this determination. Now, if you look at the issue of the welfare of the child, this is very much prevalent in assisted reproduction legislation in the Western world, that the welfare of the child is paramount. And the concern is always, it is a paramount concern. The concern is about ensuring that whatever happens, the welfare of the child is protected. However, there have been concerns expressed by a lot of commentators in this that appeals to the welfare of the child may actually be used to just reinforce the status quo, and also to perpetuate notions of what is an appropriate family. Again, who makes this decision under Head 7 is that the clinic makes the decision about the welfare of the child. Again, there is no requirement to have any discussion with the person or people who are accessing fertility treatment. So we have a situation in which a person or couple is going to go forward for fertility treatment, but they may be declined it, either medical grounds or because of the welfare of the child. The only requirement is that the clinic must communicate to the person or the individual that they cannot access fertility treatment, but there is no grounds for appeal. So if you are unhappy or you're worried that you've been discriminated against, there is no appeal to the independent regulator. Another concern that I would have is that the clinic is going to be there to support you and help you and guide you and provide you with treatment. For fertility treatment, but they also may be the same clinic who may obtain a license so that they can do pre-implantation genetic diagnosis. So we may have a doctor who's making a decision about whether or not you having a child will impact upon the welfare of the child, and you may have a particular disability. But you may also have a patient who wants to screen out an embryo with your potential disability. And considering the dual role they may be operating, is it so wise that they should actually be the person who's making the decision about whether or not you should be able to access fertility treatment? I'm not saying that doctors who are there to support you and guide you are making the discriminatory decisions. I'm just querying whether or not there is some inherent bias in the decision. The question earlier on before tea was about whether or not we should actually have these discussions with the doctors. And I really do think that it is important conversations to be having. Another issue is to do with embryo and gamete donation. The bill says that if you, for whatever reason, need to get a gamete, egg or sperm, or an embryo so that you can have for assisted reproduction, you have access irrespective of gender, marital status, or sexual orientation. And throughout the bill and in the explanatory notes, we see appeals to ensuring that there is no discrimination on grounds of gender, marital status, or sexual orientation, but absolutely no word of all the other forms of discrimination, including disability. And in Head 20, so if you, as a person with a disability or a person generally, want to actually donate embryos or gametes, you have to undergo a detailed medical assessment, and refusals must be given if you, a reason must be given for your refusal, without actually no requirement to have a discussion with you. The final point I want to mention is this independent regulator, and this. So I've done some empirical work with regards to this bill, and but in the context of embryonic stem cell research. And throughout those interviews, they said, because they did reflect upon assisted reproduction, that we need an independent regulatory authority. It's great. It's been modelled around the Human Fertilisation and Embryo Authority, which is good because although it's quite a liberal regime, it is a very strict regime, and it is seen as a gold standard. Now, it has a number of powers, or it's going to have, which is to license clinics, develop a register of licensed clinics, which we do need, provide advice and guidance, and publish and maintain codes of conduct, again, something that we do need. There is a duty to provide information, and that is to the minister only. There is no obligation to provide any information to the public. But the biggest concern I have is that there's no empowerment to investigate complaints or censor clinics. And considering the power that these clinics have in whether or not you can access fertility treatment, it is very much a concern that I would have, and it is something that they should change. The Human Fertilisation Embryology Authority in the UK does have that power, and it is something that they should change. And the final point I would like to end on is that currently it is undergoing pre-legislative scrutiny, but their concern has been on surrogacy primarily. And there has been, at the moment, no voice from disability rights activists or disability groups on this. In preparing for this presentation, I did contact a number of fertility support groups because I wanted to make sure that I wasn't missing something, that there wasn't guidance somewhere that I couldn't see. And all of them said, well, actually, we hadn't even thought about it, and you are the first person to actually ask us these questions. So I think the outcomes of this project, as this bill is going through Parliament, should influence some of those discussions. Thank you.
Thank you very much. much, Ciara. That was really, really interesting. I think I had sort of thought there'd be language in a law that on the face of it is very neutral, but if you dig down then to try and find what the barriers to persons with disabilities are, they're kind of in there. But to see that it's actually outwardly nearly discriminatory to exclude like so many important groups in the non-discriminatory grounds is really surprising. So we'll open it up now. I'm sure we've all had a chance to kind of reflect on the really interesting stories and the information that we've heard in the last while. So I'll open it up to questions if anyone. Okay. So yeah, there's just one up in the middle. I think it's Ruth.